Thank you so much for joining today for this journal club. I'm excited to see everybody. The article that we're going to be talking about today is a meta-analysis, so it's a little bit different than some of the other articles that we've talked about in the past. This article was selected by our colleagues in Rwanda, so I hope this is particularly meaningful, and I hope that there'll be lots of discussion. I am going to apologize in advance that I have a little bit of a cold and my voice is kind of crackly. And again, I hope that there's lots of interaction and people will fill in the gaps in my voice for me today. Um, I hope you all received it or have access to it and have been able to enjoy reading it and taking a look at it. And I thank you all for being here. So first, as I mentioned, this is going to be intrauterine device use and ovarian cancer risk. It's a systematic review and meta-analysis. So with the introduction, they start talking about the rationale for this meta-analysis. Ovarian cancer is the most lethal of all gynecologic malignancies. It's estimated to be about 22,000 annual deaths worldwide. 75% of ovarian cancer cases present at an advanced stage, and there are few effective screening methods. Certain family planning methods have been found to decrease risk of ovarian cancer. For example, there is a 50% reduction of the incidence of ovarian cancer among those who use combined oral contraceptives for more than 10 years. As well, tubal ligation is also associated with a reduced risk of ovarian cancer. And so, in light of the promising known benefit of other forms of contraception on ovarian cancer risk, they sought to explore the association between intrauterine device use and ovarian cancer risk through a rigorous systematic review and meta-analysis. That was the gap of knowledge that they were looking into. So the introduction was fairly short. Most of the paper was on their search and statistics, but we'll stop here for a minute and just kind of take a look at this and say some comments on it. Does the background tell us exactly what the gap of knowledge is that they were looking into? Is the purpose of the systematic review reasonable? Is it clearly stated? Do they clearly specify what the intervention or the exposure is going to be in this particular meta-analysis, and is the outcome that they're looking for in this meta-analysis also clearly described? Those are things that are important in a meta-analysis. What is the exposure and what is the outcome that you're looking for? Anybody have any comments about this? Are they clear about what they're doing and why they're going to be doing it? When you read their introduction, were you convinced, yes, this is worth doing and it's clear what they're going to
do? I think in light of your questions, it's a little bit short, and but most of the things that you try to ask in the address in the questions have been mentioned in the introduction section. So except that it's very brief, the things that you mentioned are somehow addressed in the introduction section.
Okay. Yeah, I thought it was an interesting question too. And I was interested in reading on when I saw the introduction. We're going to go on to the methods. So they first described their search strategy, which is very important for a meta-analysis and systematic reviews. They did a comprehensive literature search, and this was performed by a medical librarian, so somebody with expertise, particularly in doing search strategy. So that's an important feature. They looked at 4 different databases, Medline, Embase, Cochrane Library, and the Web of Science Core Collection. They described their methods for their search strategy, including the terms that they used. They used intrauterine devices and ovarian neoplasms, but then also used just individual terms and partial terms to try to make sure that they were capturing all of the articles. They also did a Google Scholar search and used the keywords intrauterine device and ovarian cancer. And in addition, they looked in clinicaltrials.gov for IUDs and ovarian cancer to look for current trials, ongoing trials, and things that might have been recently published to make sure nothing was missed. They use Covidence systemic review software to screen and review the text. They had one investigator that reviewed the title and the abstract of each report, and a second investigator consulted on eligibility concerns. So this was to initially look at the abstract and select the ones that were going to be used for full review later. And they had specific inclusion and exclusion criteria mentioned in the meta-analysis in the search strategy. So for the inclusion criteria, the article had to have individual level data. There had to be a history of IUD use, a diagnosis of ovarian cancer. The exclusion criteria where they did not include case reports, they didn't include reviews, and they didn't include any reports that looked at IUD within the context of menopausal hormone therapy because of the potential confounding involved there. And they talked about what they did once they found that group of studies that they had selected. Then they did data extraction from those. So they had two investigators that reviewed all of those included studies independently for the full text. They identified studies that had been evaluated for ovarian cancer incidence and ever use of an IUD with individual level data. They included studies that were case control and cohort studies. So those were the two types of designs that they included. The case control studies had to have a defined control group that did not have ovarian cancer, and the cohort studies had to have ovarian cancer as an outcome variable and the IUD as an exposure. And then any studies that had duplicate populations, so some studies, there may be in some studies where maybe they initially had 500 people and then they had a larger population later. If the same population was included in multiple studies, they did not use those studies over and over again. They ended up just using the study that had the largest population of the same people. So from the studies, they extracted geographic location, years of data collection, year of publication, the study size, the characteristics of the study population, and they also collected particular covariates that included age, menopause status, gravidity, history of oral contraceptive use, BMI, and family history of cancer as things that might affect your development of ovarian cancer. They did also try to extract the type of IUD that was used, whether it was a progestin-releasing IUD or the copper IUD, and the method of diagnosis of the ovarian cancer, the pathology report, and the histologic subtype. When they could not find these information, they did contact authors by email to see if they could identify that information. And then they also looked for study-specific biases that might exist within particular studies. So let's stop here for a minute and look at the methods. So things to consider within meta-analysis are things like, was a database search appropriate and comprehensive? Other things to consider are the keywords appropriate and comprehensive? Did they really capture the things that you want to identify to get all of the papers? And did they also capture keywords that would abbreviate some of the main words that you're looking for? Do they have inclusion and exclusion criteria up front? Are the search results provided at the end, like a link or an appendix? That's something that needs to be in the meta-analysis. was the quality of the each study assessed using predetermined criteria? And were there at least two independent investigators doing the selection and the extracting? And are they collecting the appropriate variables out of those studies once they identify which studies are going to use? Those are all things that are important in the selection and extraction of data for a meta-analysis. There are other things as well, but those are probably like the biggest things that we should be looking at when we're looking at a meta-analysis. So I'm going to stop here and just ask people what you think based on reading the study and the brief review I just did for you on this.
The database used in this study was explained by the search engine that they used, and I guess the key terms that they used, they tried to cover every IUD, every single report have been done on IUD and ovarian cancer, and they also made good like they tried to give us about the confounding the confounders, and they made a plan to exclude them.
It's a pretty broad search.
So another thing is the inclusion and the exclusion criteria are not really clear. They exclude a lot of things that might maybe confuse someone who read this paper. And then I don't see why they excluded the case reports.
From the introduction, it seems broader, and it described family planning in general, then specifically to IUCD. Okay? So it seems there is no studies were mentioned in the introduction. So why the author jumped from family planning in general to specific IUCD? This is my previous comment. And in the method, it seems good, but the key terms are not exclusive. For instance, malignancy is missed. Tumor, for instance, they may use some of them tumor. So I found it's not comprehensive. Malignancy is common. Commonly they write malignancy instead of cancer, for instance. This is my comment from the slides I have got.
Okay, so you think they might have missed some by not using some of the other words for cancer? That's a good point. Excellent. Yeah, the words that you use for your search strategy are absolutely critical, because if you don't have the you don't have a comprehensive enough search strategy and you miss things, and that's, if you don't have all the papers, that's the most critical thing, to have all of the evidence. Yeah, those are great points. Thank you, everybody.
Another thing maybe is they didn't use any predetermined methodology to assess the quality of the papers that were selected. So there are different ways of assessing the quality of the evidence. Mm-hmm. So probably they didn't use any of the methods that are known to assess the quality of the evidence.
Right. They just made sure they had common exposure. Yeah. Can you comment on what some of those techniques are for adding in quality of papers?
Yeah, the grade system, for instance, can be used to assess the quality of the evidence. So there are a number of items that need to be checked in each one of the papers that are selected in order to assess the quality. And based on that, the quality can be graded in that way. So that is just an example. So there could be also other methods that can be used to assess the quality. So that is missing in the methods part.
In the review. Okay. Thank you. And can you comment on the use of case reports in data collection?
I do agree on the inclusion of case reports because case reports are not as strong as the designs that they selected, the case report, the case control studies or cohort studies. So depending on the strength of the design, case reports shouldn't be used as a source of evidence for this kind of meta-analysis. So I would agree also with the authors as to the exclusion of case reports. That's mainly on the strength of the design. So that's the only reason.
Okay. All right, we're going to go back to the paper and go to the statistics plan. So to evaluate the association between the ovarian cancer and IUD use, they used the raw numbers that were in each article to calculate the effect size. They estimated the summary odds ratio association between any use of IUD compared to no use of IUD and ovarian cancer risk using a fixed and random effects model. And then they performed meta-analysis with adjusted odds ratio for each study as well. And as I said, if there were multiple studies used of the same sample, they used the larger sample for the meta-analysis. So the primary analysis was on the combined of cohort and case control studies, and then they did additional subgroup analyses for the case control studies alone, of which they had more. They did forest plots to show each study's contribution to the summary estimate that they came up with, and they did a heterogeneity calculation with I-squared test. And then the statistics analysis was performed with Review Manager 5.3. So in looking at the statistics that they planned, do we think that the methods for quantitative pooling of the individual data seem like a reasonable plan? And considering that they have like different study designs and everything, are they adequately addressing that there can be risk of bias, and is a similarity of results between studies or differences between studies being assessed with this statistical plan that they have developed for this meta-analysis? I think these are things to consider. There are probably other things to consider that you may bring up, but these are some of the things I thought would be worth talking about. So what do people think about this statistical plan? I think an odds ratio is a very typical type of statistics to do for meta-analysis. Some sort of relative risk or odds ratio is the typical output from this type of evaluation. And then the heterogeneity test that they talked about, I think, is also pretty common, either with chi-squared or the I-squared, to look and see whether the study results from the individual studies that you had are fairly similar or different. So they do have that in there. So I think those things are pretty standard within meta-analyses. Dr. McKenny, do you have any comments about, does this plan look like a standard plan, or is some things missing?
I think it's quite comprehensive when I see it, given the two types of designs that were selected for this meta-analysis. The data extraction is okay, and they have also tried to reach out to the authors if there are missing outcomes not reported in those particular papers they selected for systematic review and meta-analysis. And they looked at also heterogeneity and also publication bias by using different methods. They calculated I-squared statistics, and they also did funnel plots to look at publication bias. So in that sense, they have addressed some of the issues that may not have addressed by identifying appropriate papers. So statistically speaking, I think I'm comfortable.
Anybody have any other comments about the planned statistics? I'll just say one thing I didn't see in there explained that does come up in the results is the weighting of the studies. They didn't really talk about how that gets determined, but they have in the results how they weighted the weighting that they gave to each of the studies. There was no real explanation of what they were going to do. I don't know if that's just...
Yeah, I think they have used the random effect model, which addresses different weighting methods. For smaller studies, the larger weight is given. For larger studies, smaller weight is given. So by using a random effect model, they have addressed that particular issue. So they use both fixed and random effect model in their analysis. So random effect model is the most appropriate one. So they have reported that as well, which addresses the small with the smaller studies given larger weight in the analysis. So they have provided the forest plot for both in the results section.
Okay. All right. So we're going to keep going. Look at our results. All right, so they, in the databases, identified 399 unique reports. But of course, as was mentioned, that if you don't have all of the right search words in there and you miss critical ones, that may have not been all of the important ones to capture. Many were eliminated due to study type or topic. 53 reports were included in the full text review. So after they went through the abstracts and picked which ones they were going to actually look at in detail, that was 53. Many of those were eliminated due to study design, patient population, intervention, or language. And then they had 15 reports that met all the inclusion criteria. 6 of those were removed due to overlapping populations or lack of control, or they didn't have a cancer outcome or a study structure issue. In Google Scholar search, they identified 2 non-duplicate reports that they added to this list. In the clinicaltrials.gov, they found no articles that met inclusion criteria. So overall, they had 11 studies for data extraction, 9 case controls, and 2 cohort studies. And they did have a nice diagram that described this and the names of the studies to show what happened with the information and article flow and where they dropped out. So they do show the 9 case control studies that were included. Let me see if I have. Yeah. And I just wanted to point out that they do have pretty international populations. They have populations included from Europe, from Asia, Vietnam, China, from Mexico, from the United States. There are no populations from continent of Africa, but there are pretty international representation among the populations. They do also have populations from hospital and clinic communities. And within the case control studies, you can see that there were a total of about 9,000 participants, 4,400 of those with cancer. And then they show the different adjustments that they made here for parity, the information they had for parity, BMI, and tubal ligation. And then for the two cohort studies, one from Europe, one from Asia, you can see these had a lot larger numbers. So they had a total of 174,000 participants, 649 with cancer, 48,000 were IUD users, and they all had age parity and BMI. So for the results of the meta-analysis, for the summary odds ratio association between ever use of an IUD and ovarian cancer, the odds ratio is 0.68. So a reduction in the risk of ovarian cancer if you ever used an IUD. The confidence interval did not cross 1, so this is significant. When they separated and did the subgroup analysis for just the case control studies, the summary odds ratio was pretty much the same, 0.68, also significant. And with just the cohort studies, those two cohort studies, the odds ratio between ever use of the IUD and ovarian cancer was still about the same, 0.66, and also significant. And this just shows you all of the studies, shows you how they were weighted. And I guess this is what I didn't understand, Dr. McKetty, was these were such large populations. I thought they would be weighted greater, but they were weighted around 9 and 8%. So that's what I didn't understand. Overall, 0.68, as we said. And this is pretty much the same information. Another representation. This is an example that they showed of their forest plot that basically just shows the information in a different way. Almost all the meta-analyses have this. This line going down here at 1 would be no effect. You're on the right side of this. This would favor that IUD use caused increased risk of cancer, and if you're or is associated with increased risk of cancer, and if you're on this side of that line, it would be that IUD was associated with reduced risk of cancer, and you can see the 0.68 down at the bottom is the total, and then all the studies you can see above, you can see what they contributed. And pretty much almost all of them are over on that left side. So it was pretty consistent all the way down. So it's a nice visual representation. And this is the funnel plot, which looks at it's another way of visualizing that heterogeneity that we were talking about. So the heterogeneity test at I-squared was 68%. So that's, I think, pretty high, showing significant variance between the studies, but they comment that that's probably related to having a low number of studies. They did this funnel plot that shows the 95% confidence intervals, and that most of the studies fell within the 95% confidence intervals for the for the odds ratio. So there were only a couple studies that were outside of it. And then the next analysis that they did was the analysis using the adjusted odds ratio from the studies. And they do show all the adjustments that the studies did. That's in the center. This column in the middle shows all the different adjustments that all the studies did. In addition to the standard ones on the left. Birth control, menopause status, family history of cancer, and the odds ratios are over here on the right. And so for the adjusted odds ratio analysis, the combination odds ratio was 0.85, again significant. Heterogeneity was similar at 69%. In the funnel plot, the majority were in the 95% confidence intervals, and overall this was the same result. And then they looked at the covariates from each study reviewed. In the logistic regression, all of the studies used age parity and oral contraceptive use, and the other things that were used were BMI, tubal ligation, menopause status, family history of cancer. Most use that, but not all. So they did a meta-analysis stratified based on whether studies included a given covariate. And again, it was pretty much the same. And this was the results. Again, you can see the summary odds ratio, pretty much consistent with what we've seen before. And there were just a couple that crossed one over here when they did not address certain things like tubal ligation and family history. It was not significant. Okay, so in looking at the results, I think the main things to look at is the primary research question answered? Were the results presented in a way that was logical and understandable? Were there any other data analysis that would have enhanced this research that they did? And is that heterogeneity issue adequately addressed? Are we satisfied that the studies were similar enough to be compared? I think those are probably the most critical questions here. Of course, you may have some other ones. Those are just some of the ones I thought were worth asking. Okay, what do you guys think? When you read the results, was that section pretty clear to you, or were some things confusing? Did they convince you?
I think the result is quite comprehensive, and the way it's presented is also logical and somehow convincing. They have done in the result. They have done they have checked heterogeneity and also publication bias, and also did subgroup analysis by study design. Previously, when I said weights in the smaller studies, it was relative. Still, larger studies still have higher weights, but if you look at smaller studies, the relative weight is relatively higher. Otherwise, still the larger studies do have higher weights in the forest plot, as you mentioned. So when you look at, they also looked at the forest plot using adjusted odds ratios, which makes it also very strong because, as you can see, the overall odds ratio changes when they use the adjusted odds ratio compared to an adjusted one. So the effect is smaller when they use the adjusted odds ratio because all the covariates in each of the different studies were adjusted, and they looked at adjusted odds ratio separately, and as you can see, the overall effect is smaller than when they are not using the unadjusted odds ratios. So overall, the study, I mean the analysis and the presentation is convincing, and it's quite comprehensive, I would say.
I was really hoping that they would have information about the type of IUD, the progestin releasing, or the Paragard IUD. That's what I was really hoping for that.
That was the comment I was going to.
Yeah.
It's not impressed whether it was copper IUD or the hormonal IUD, and especially in the exclusion criteria, the way they specified that whether IUD was used for hormone replacement was part of the exclusion criteria, but then here they did not differentiate, they did not clearly tell us which the difference between the non-hormonal terms of the price of ovaries. But at the end, if you check well in what they describe, it looks like the primary question was answered, even though it's not yet clearly differentiated in terms of type of IUD used.
Anybody like to know how many years you need to use an IUD to have reduced risk of ovarian cancer? I didn't see any data like that. That'd be nice to know.
Not answered.
Those are the things that are mentioned in the limitations of the systematic review. If you look at the discussion section, probably we'll come to that later on. But they mentioned that in the limitation of the review. Probably I was hoping to talk about it later in the discussion section, where they mentioned some of the limitations, which you just mentioned.
Yeah. Okay. Well, let's keep going then.
They didn't calculate the duration. They didn't see the duration of IUD use and the outcome of interest, which is decreased risk of ovarian cancer.
So in the discussion, they first summarize and say the meta-analysis showed that every use of an IUD was associated with a significant lower incidence of ovarian cancer. The pooled data showed a 32% decrease in the incidence. Analysis of adjusted odds ratio confirmed the inverse association between IUD use and ovarian cancer, and it was confirmed when stratified by the covariates. They had a comparison. They said that studies suggest that IUD use can reduce risk and help manage other forms of cancer. So they point out that the progestin IUD is used to manage low-risk pre-invasive endometrial lesions like hyperplasia or complex EIN. They point out that the copper IUD reduces the risk of endometrial cancer as well, and that the IUD decreases the risk of cervical cancer. And then they provide a mechanism why any type of IUD might reduce risk of ovarian cancer. Metal-based devices alter the pH of the reproductive tract, and this is implicated in prevention of carcinogenesis. The hormone-releasing IUD exerts an anti-estrogenic effect, and this inhibition may prevent cell division in the ovary and prevent carcinogenesis. And all IUDs cause some inflammation, and that may activate local immune cells to eradicate occult cancer cells. So they provide a mechanism for why this might occur. They point out the strengths of the study. that they had a rigorous algorithm that ensured that only case control and cohort studies were included. Authors were contacted for additional missing data and for clarification. And the data represents diverse populations around the globe, and I just pointed out that that did not include Africa. They point out limitations, that they had no comparison of any IUD use to non-use of IUD in the general population. The randomized controls study design is not feasible for this kind of study, so they used designs that were feasible for this kind of study. Data was at risk of biases in the initial study design, so case control studies and cohort studies are at risk for bias, and so if you have a study design that has risk for bias at the beginning, that bias can be carried into your meta-analysis. There's a potential for confounding factors. It's unclear if there's a linear relationship between the length of IUD use or the magnitude of the association. And you cannot assess the effect of different types of IUDs because this is kind of one composite variable. They weren't able to separate it. And so then I just bring up how can we apply this to our care of women locally? Is there anything that we would want to change in how we currently counsel women? You know, how would we consider this information in what we do currently? And is this enough information to change anything that we do currently?
This information can be used in our settings. Like, for instance, hospital in Kigali has the biggest referral hospitals of the country, where we are also the hospital that receives the biggest number, if not all, the women with gynecology cancer. That includes ovarian tumors. So we part of the preventive measures that comprise both contraceptives and prevention to ovarian tumors are we do salpingectomy instead of BTL. In case a woman will prefer sterilization methods, we usually offer salpingectomy as compared to BTL only. So now, with this data that is described with this paper, now we know by offering an IUD, there is still some decrease in chances of having ovarian tumor.
Yeah, I think it's a nice thing to have in a nice fact to have in our armamentarium that we can talk to patients about and give them some reassurance about another option. And also just in telling them about risks and benefits when patients are concerned about things is another thing to just say, well, this may actually give you this, may lighten your bleeding, it may give you this additional benefit as well, so I think that's another thing to consider. It's nice to know that there may be some additional opportunities to help women.
Yeah, and also for academic purpose, also when we are teaching, giving information to students or trainees, telling them the benefits of the IUD, not only for contraceptive, but it has also some other health benefits. And for those people who are like in our context, where IUD, some religious people would think it's just an abortifacient. That's how it only works when used as contraceptives. So now another value is added on top of it when we are explaining people and trying to convince them by when we have data, statistics like this that can show that it's not only for contraceptive. You can use it only for it has some benefits. Yes, it's not a primary or the gold standard to prevent ovarian cancer, but it has that small benefits in it. And as more ideas come on the benefits of contraceptives, we are also increasing the likelihood of the uptake of.
Yeah, it goes in a positive category, right? Something else in the positive category for it.
From clinical perspective, I think it will add some additional value in the counseling, especially for those with family history of ovarian cancer. People will consider it seriously if we add it has some clinical benefit in reducing ovarian cancer.
It is always a struggle in those patients that have some of those histories of breast and ovarian where oral contraceptive pills will help with their ovarian, but you worry about their breast, right? So I wanted to just end with a couple of slides at the end so this will all be available on the CIRHT website, but Preet, our medical librarian, could not be here today, but she was very kind to provide some references for people who want more information about meta-analyses and reviews in general. So this is a paper that Preet recommends that goes over all the different kinds of review papers, of which there are like 14 different kind of reviews. We're talking about systematic reviews, but really there are 14 different kinds of reviews, and this talks about all of them. So you can differentiate. And then these are resources for systematic reviews, how to look at systematic reviews when you're reading them, but also if you were involved in one, the different kind of things that you're thinking about, and just provides a lot of different information about them for your own use. So just wanted to provide those for you in case you're interested for more information. It was great seeing everybody today. Appreciate all the comments and participation. It was great talking with everybody, and thank you for picking out this article. It's really fun for me to read and go over. I haven't done a lot of work with meta-analyses before, so this is fun for me too.
Thank you very much.
Thank you.
Thank you, Dr. McKinney.
Okay, thanks.
Thank you. Bye.